Welcome to the ICU podcast, where we explore the vestibular experience through conversations between patients and the health professionals who care for them.
During this podcast, we invite patients to share their stories and healthcare professionals to ask questions so they are equipped to better care for and truly see the invisible challenges faced by their patients. I'm Kimberly Warner.
And I'm Cynthia Ryan, and we are your hosts on this journey of discovery.
Welcome, everyone, to the ICU podcast. I've lost count, but I think we're somewhere around maybe 16 episodes now. And I'm really looking forward to today's discussion. It's very personal to me. 8 years ago, I developed symptoms of Mal de Debarquement Syndrome. But because it's somewhat rare, it took 4.5 years to get a diagnosis. That's a long time without community, hope, and help. So I'm particularly excited about today, where we connect with one of the leading researchers in MdDS and an MdDS patient who has tried a slew of treatments and now runs an MdDS support group. Mal de Debarquement Syndrome is a central vestibular disorder that typically arises following exposure to passive motion, such as a boat, airplane, or automobile. The characteristic symptom of MdDS is a constant sensation of rocking, swaying, and or bobbing, which I'm experiencing right now. While the most common onset for MdDS is exposure to passive motion, there is a subset within this clinical population who cannot attribute the onset of their symptoms to a motion event, but rather to a non-motion event. Or it may occur spontaneously, as in my case. Non-motion events that have been associated with an onset of MdDS symptoms include surgery, childbirth, medication changes, traumatic experiences, and minor head injuries. So research into both subtypes is ongoing in the hope to identify similarities and differences between them and to clarify a potential classification as well as treatment. Our first guest, as I mentioned, is Dr. Yoon Hee Cha. She is an associate professor in the Department of Neurology with a subspecialty training in neurotology. She joined the faculty of the department in July 2019 to pursue research on the application of non-invasive brain stimulation methods on the modulation of motion perception, treatment of vertigo, and enhancement of gait and balance. She developed the first neuromodulation-based clinical trials in MdDS. The study of MdDS revealed the importance of brain regions not traditionally thought to be part of the vestibular system in the creation of motion perception. Understanding how motion entrainment can affect multiple resting state brain networks provided insights into why migraine, anxiety, and cognitive dysfunction are frequently comorbidities with vestibular disorders. Besides research on use of non-invasive brain stimulation tools such as transcranial alternating current stimulation and transcranial magnetic stimulation, those are mouthfuls, Dr. Cha sees patients in the neurology clinic with a focus on chronic headache, vertigo, and gait dysfunction. So there's a lot there. We have so much to discuss today. We're delighted to have you here, Dr. Cha.
Thank you for having me.
Welcome, Dr. Cha. I would like to introduce our other guest, Nancy Gray, who has lived with 24/7 symptoms of MdDS for 4.5 years now. It started when she disembarked from an Atlantic Ocean crossing where she was sailing from Lisbon to Miami. After 3 weeks of feeling like she was in continuous motion, which I'm sure those of you who have MdDS who are listening today can totally relate to. She called an ENT for an appointment, but had to wait 1.5 months to be seen. Then in 2021, she worked with Dr. Sergey Yagushin at Mount Sinai for a week of treatment, which improved her symptoms to a level 2. So maybe later on we can talk about what level, what the different levels mean. Nancy continues to travel by boat. She says that since she feels like she's on one, she might as well be on a real one anyway. Her hobbies include travel, playing a hammered dulcimer, watercolor, collage, writing, photography, genealogy, research, and gardening. MdDS has affected all of these, and she's had to adapt ways to continue to enjoy them. Welcome, Nancy.
Thank you.
Yay. So let's start, Nancy, with you telling us just a little bit about your vestibular journey.
Okay. Well, yeah, I had traveled, I had been on several cruises prior to developing what I refer to as now chronic MdDS. And every time I had gotten off of a ship in the past, I would experience motion for 2 to 3 weeks after disembarking. But I never knew that it was a condition of any sort. I just thought, well, it's just me. And and it would always go away. So it, I never sought any answers about it, didn't research it. It was just something that I anticipated. So then in 2019, when I took my last cruise before developing chronic symptoms of this, I got off the boat and I didn't wait. I didn't contact the ENT for at least 3 weeks because I expected it to last for that long. And when it didn't go away, I was like, okay, something's different this time. And my sensation of motion was more pronounced. So at that point, I called to make an appointment with a local ENT, wasn't able to get in for that month and a half. And I actually said to the receptionist, maybe this will go away before I come and I can just cancel the appointment. And so when the day came and I went for the appointment, it had not gone away. So went in, sat down, and Dr. Blatchford is who I saw. And he asked me some questions. And I said, I was on a cruise. I got off. I still feel like I'm on the boat. Now it's been more than 6 weeks. And I still feel the motion of the ocean. And he asked me if I was experiencing any nausea. Nope, never have. Um, how did I feel when I was in a car? I felt like I was normal. Um, how did I feel, at doing different things? And so, I answered all the questions. And all of a sudden he said, I'm going to write this down for you. And you're going to need to do research on it. And he wrote down on a piece of paper, Mal de Debarquement Syndrome. And that was the first time I had ever seen the word, heard of it, or anything. And I was like, seriously, they had to give it a French name? That's difficult to pronounce. And I just had to laugh. It was like, okay, fine. So I said, well, when is this going to go away? How long is this going to last? And he said, well, I'm going to hope for you that it'll go away, in a few weeks, maybe another month or two. But if it doesn't, unfortunately, there really is no cure for this. And I suggest that you do some research online, and and then contact me if you need any more information. Um, I went home, Googled it, of course, and was immediately in a state of shock over what I found. Um, and so then I started researching and I found information about the program at Mount Sinai. I contacted Sergei Yakushin at Mount Sinai and found out, okay, I needed to have a VNG caloric test. My own doctor recommended, because I think she didn't believe that this was actually the case. So she was like, I think we need to do an MRI. So I had an MRI done with a contrast study that all showed everything in my brain that you could tell looked normal. There wasn't any tumor. There wasn't anything showing anything specific. The VNG test came back normal. They tried doing the Epley maneuver on me. That didn't do anything. So then they also recommended, well, go for vestibular rehabilitation. So I contacted a PT. I tried all kinds of eye exercises. They made me so much worse that I was like, okay, this is not working for me. And my husband would often comment when he'd come pick me up after my appointment, he'd say, you're worse now than when I brought you. I thought this was supposed to help you. And I said, exactly. But, it is what it is. Um, then the pandemic occurred, and I thought, well, since I'm not going anywhere, maybe just sitting, just walking around my house, not going out and about, maybe it will calm everything down and it will go away. Well, after a year and a half of that, nothing went away. My symptoms were the same, they sometimes were worse. By then, I had been accepted into Mount Sinai's program. So we flew back to New Hampshire, and then I went to New York City for a week and went through their program. I will say the working with Dr. Yakushin, my symptoms went from not being able to stand unaided without hanging on to things to keep my balance to at least being able to stand. I went from feeling like I was on 35-foot waves to feeling like I was on much gentler water that was just kind of like this instead of wildly swinging. So I was pretty happy. It was like, okay, it reduced my symptoms. This is good. I came back home to New Hampshire, where we stayed for the next 3 months. I was able to walk outside without having to hang on to things. So I thought, okay, this is good. I can live this way. Then we flew back to Arizona, and everything was retriggered. And I was back to symptoms that were even worse than they were before. Um, I went through a period of time of hoping this was going to go away, then finally accepting that, okay, this is what it is. I'm never going to give up hope, but I also made the decision that I was not going to sit and hope and let my life go by, that I was just going to figure out ways to do the things I enjoy doing. And so we booked a river cruise over in Portugal to see could I handle that. And I was able to handle, being on the boat. I did start using a rollator walker when I travel because it's the only way that I can ensure that I can keep my balance. And frankly, I walk faster than normal people with my walk. So I tease my husband all the time and I say, someday I'm getting a jacket, and on the back it's going to say, in spite of what you're thinking, try to keep up. So,
Oh, Nancy, I,
well,
your story, I mean, replacing a few details, I can relate to everything you just shared. And I'm eager to hear more of the details about this because, my goodness, I it's always shocking to me. I've spoken to so many MdDS patients over the last 4 years since I finally discovered what I was living with. And our stories are so similar. I mean, I know vestibular patients as a whole are, but then when you get into that subset, it's like, my goodness. I just feel a little ache actually, just revisiting your story and going, I know. Let's bring Dr. Cha though into this discussion for a minute. I want to hear, because this is such a unique condition. I'm interested in what brought you into working with vestibular patients, but even more specifically, MdDS.
Yes, well, thank you for the invitation. This is a really important format for disseminating information to patients, and I would echo that Nancy's story is one that I've heard hundreds of times now, and these commonalities are very important to pay attention to because they are what allow you to kind of figure out what are important hypotheses to test. So how I got interested in working with vestibular patients is that I did my neurology residency at UCSF, which you might know is one of the busiest, toughest neurology programs in the country, and you learn how to take care of the sickest patients with hemorrhages and inflammatory crises and neuromuscular collapse. But literally like none of my attendings who were incredibly smart, incredibly famous. Like not a single one knew how to work up dizziness. And the basic premise was, if the patient doesn't have a stroke, it can't be that serious. And so a lot of patients were just kind of left without a diagnosis. So if it can't kill you, you're just going to have to live with it. So I actually decided to do a neurotology fellowship, really to just round out my education as a neurologist. And I had actually considered going into ophthalmology instead of neurology. So going to into neurotology made sense because of all the importance of eye movement disorders in the vestibular world. But when I started seeing patients with my mentor Robert Balo at UCLA, I realized very quickly that patients with MdDS were a understudied population. I mean, we could diagnose them, but unlike patients with other vestibular disorders like, Meniere's or BPPV or even, cerebral strokes, we didn't have much to offer them in 2006, right? There was nothing by way of treatment or prognosis. And at the time, there were only 12 case reports and small case series on MdDS. So that's when I decided to contact Dr. Balo's MdDS patients. He had an amazing secretary who was with him for 25 years, who had databased all of his patients. There were about 12,000 patients in that database at that time. And I tried to contact every single one of them. And I spent about 2 to 3 hours talking to each person, trying to figure out what these commonalities were, demographics, risk factors, and, how long did they have their symptoms? How many episodes did they have? And what basically came out of that was this heightened sensitivity to visual motion. And that was kind of the launching off point of where the neuroimaging, the neuromodulation, and then now the vascular work that I'm doing came from.
I want to put a pin in that heightened sensitivity to visual motion because that seems like a really important key that we need to talk more about.
Yeah.
Absolutely.
Yes.
And Nancy, when you were talking, I had so many questions going through my head, and I didn't write them all down. So I'm going to jump around a little bit, but I want to start with your visit to Mount Sinai for your treatment. And also, actually, I want to, before I do that, I just wanted to note, I thought it was really interesting that you got an MdDS diagnosis with the first healthcare professional that you saw, and then they started treating you for other things. They started treating you for BPPV, and they sent you to vestibular rehab therapy, and that's just so interesting. I mean, if they knew what it was, why try to treat you for BPPV?
Well, I think actually, see, I'll back it up then. I said, should I go and maybe work with a physical therapist because my balance was so bad. And so I called two different physical therapists in the area I'm in Arizona and asked, did anyone have any experience with working with people with Mal de Debarquement syndrome? Well, first of all, they've never heard of it. So, no, of course, they have no knowledge. So I went to work with a physical therapist who had never heard of this condition. And so she did a little bit of research. And so, based on that, she decided what to try to do for me. Now, interestingly enough, I'll back this up even a little further. The ENT that I went to see, what I found out later, he didn't tell me at that appointment, but the reason he could diagnose me and so quickly is he himself had experienced Mal de Debarquement syndrome several years prior after a 2-week trip on a sailboat. He experienced MdDS for 3 months and then went back into remission and being normal. So that was how he even knew of the condition, how he even knew when I said, okay, I got off of a boat and I still feel like I'm on it. He knew exactly what I was experiencing because he had. And then he retired not long after diagnosing me. So I can't see him anymore. But anyway,
Good time.
that
Good time.
was,
At least you got him.
yeah, and I had just hoped that maybe going for physical therapy that it might help
Right.
me. and it didn't. So
Well, then, so tell us about the week-long treatment you had at Mount Sinai.
okay.
What
Um,
did you, what was that? What did that entail?
Well, of course, I had to send them all my test results in order to be accepted into the program, and I was accepted into the program because I fit all the criteria. And so I made the arrangements, and I went to New York. I took a bus down from where I live in New Hampshire, so just taking the bus I knew was going to be an issue for me. But I got there, and we chose to go down 2 days in advance so that all my symptoms could settle down just from the bus ride alone. And then I went to start working with Sergey. The the process or the treatment that I tried was not with the moving your head back and forth while you look at the optokinetic stripes. But I sat in a round booth watching, locking my eyes straight ahead on vertical stripes that rotated as I was in a chair that also rotated, sometimes in the same direction, sometimes in opposite direction. And, the first day you only do it for a few minutes and then you come out, you take a break for a few minutes, then you go back in. They build you up so that by Wednesday, I was in the booth for 25 to 30 minutes. And for the last 2 days, Thursday and Friday, I was in for 45 minutes for each session for a total of, 2 sessions. And each day, my symptoms lessened. So I was feeling very optimistic. Um, it did not get rid of all of my symptoms, which I kind of knew that going in, that that I should not expect to go in and do this and walk out and go, oh, it's gone and I'm back to normal. But it was such a remarkable difference
Yeah,
that I was very encouraged.
yeah,
And I actually did videos of myself prior to going and after when I came back to my home. And Sergey asked if he could use those videos to show other researchers the benefit
yeah,
to me at least, not necessarily everyone. So I was very hopeful. I was not taking any medication, and so I really was very hopeful. And who knows if I had not flown back to Arizona um, and just stayed here in New Hampshire, who knows? I'm
Yeah.
never going to really
but
know.
I have
you
so many
look.
questions. This is just fascinating because to me, I mean, it's there obviously, Dr. Cha, you can jump in because it sounds like there is a component here that is connected to the neurovisual system.
Mhm.
And I know for myself, because my MdDS was spontaneous, there was a physical therapist early on, right after the first neurologist I saw that said, oh, you have cervicogenic vertigo. So she was doing all these neck exercises with me and with no success. And she was the first person that said, I don't know, but I've heard of this thing called Mal de Debarquement, and it seems like that's what you have. And but she said, but you weren't on a boat. So she was confused because she didn't know that there was such a thing as spontaneous. But she mentioned this treatment in Sinai, and I was so tempted. I think I even reached out to the clinic, but they were only taking motion triggered MdDS at the time. And so anyway, long story, but I do want to hear from you specifically, Dr. Cha. It sounds like these neurovisual systems are a huge part of the MdDS experience. But can you back up a little bit and tell us what parts of the brain are traditionally thought of to be involved in our sense of motion? And then how MdDS and these more non-traditional parts of the brain that you discovered that cause a person with MdDS to feel like they're constantly in motion.
Yeah, so this is a really interesting disorder because patients with MdDS and non-motion triggered persistent oscillating vertigo have essentially the exact same symptoms, right? And the only thing that is different between the two is whether there is an identifiable motion trigger. So I do think we have to be very careful about using words like, like spontaneous MdDS, which was a term that was, used, earlier. But, with your experience, Kimberly, there's usually some type of antecedent event, whether it be a medical illness or a concussion, a whiplash, postural strain, etc. And that's part of how I got interested in, looking at the venous system. But to answer your question about why the visual system is so important, so if you think about the vestibular system is probably evolutionarily the most, like the oldest part of the nervous system, right? It's remarkably well preserved throughout evolution. If you look at the inner ears of fish or birds or whales or certainly land animals, you see that the inner ear structure is pretty similar across all of these species, even though they look completely different from the outside. And that's because, the universal challenge of all living creatures living on a planet with gravity is to know which way is up, right? So if you are a little fish living in the bottom of the ocean and there's absolutely no light, you may not need to see, but you do need to know whether you can swim up or down. And so all these other sensory systems like vision and even sound, also give you position information. And all these systems are optimized for different kinds of information, though. So, for example, the vestibular system is optimized to detect acceleration, whereas the visual system is optimized to detect velocity. And sometimes your brain is trying to figure out, like, which system should I pay attention to because it's giving me conflicting information. And that's where cognition is really important and what we call sort of top-down control. When you have to sort of make a decision in a particular situation, who am I going to pay attention to? And so at every point, your brain, wherever the sort of master control is, has to be able to kind of toggle between all of the different sensory systems, which also does include sound and proprioception, to say, okay, here is where I am in space, and here are what other things are in space, as well as my orientation to those other things. So I think if you were going to study, the entire brain with one system, it would be through the vestibular system.
Wow, that's fascinating. But now let's go a little further, because so now that the visual system, then it's clear, is connected to all vestibular, to the vestibular system in general. But then, am I right that your research includes some more non-traditional parts of the brain as well that aren't class for MdDS, but aren't maybe with Meniere's or migraine?
Yeah, so the visual system, first of all, takes up about 50% of the neurons in your brain. And that was one of the reasons why I had even considered going into ophthalmology. And then someone said, if you did neurology, you can get 100% of the brains of the neurons in the brain. So, so that was a win there. But, the visual system is incredibly complex because you have different pathways that are specialized for motion, versus shapes, versus colors, and etc. So I don't want to kind of oversimplify a very, very complex, system, even though I consider the vestibular system to be more interesting. But there are parts of the brain, like the entorhinal cortex, that we found that was hypermetabolic in patients with Mal de Debarquement syndrome, that does receive vestibular information, that is considered to be sort of like the brain's GPS system. And it's not a system where, you would have otherwise, kind of thought, would be relevant in Mal de Debarquement syndrome. But it turns out to be also an important hub because it is interconnected with so many other parts of the brain. And so, your entry point doesn't necessarily have to be the thing that is attached to everything else, right? It's just, even with 1 degree of separation, if you can get at the the neighbor that is talking to every other neighbor, sometimes you can still get the effect that you want.
Yeah. Interesting.
So Nancy, you were talking about, the PT didn't work for you.
Right.
The treatment that you received at Mount Sinai did work for you, but that was something that you had to do in the clinic, which was across the country, not something that you could just
Right.
do all the time. So I know you've had setbacks. Tell me what treatments or whether they're medical treatments or just things that you've incorporated into your life,
Right.
like activity. What has worked for you and what has
Right.
not worked for you?
Well, I did try eventually 2 medications, and neither one of them had any effect on my symptoms. So I talked to the doctor, and I don't know if I should mention, who the doctor is.
Oh yeah, we talk about our doctors here.
And I worked with Dr. Bay, and I was very happy working with him. And unfortunately, now he can't see people over telehealth, so I was no longer able to continue working with him. But I tried gabapentin first, and that had absolutely no effect other than ramping up my tinnitus, which I had had for about 7 years prior to developing MdDS. And I will say, though, the tinnitus that I had was triggered by a flu shot. It's like I got the shot one afternoon. The next day, I had ringing in my ears that has never stopped. And so, anyway, um, Dr. Bay and I decided then no, the gabapentin was not doing anything for me, so I should wean myself off of that, which I did. And then I tried Effexor was the next one to give a try, and I tried that for 4 months, and that had no effect at all on my symptoms. And I even emailed Kimberly because I said, "Okay, how long before you felt any improvement?" She goes, "Oh, well, it was like within a few days." I was like, "Oh no, I've been on this now, 3 months and there's no change." One thing I do feel, and so currently I'm only on vitamins now and over the counter, things like I take turmeric and I take all kinds of vitamin B tablets. And anyway, I decided, okay, fine. If the medications aren't really working for me, then I'll go back to just, trying to do this on my own. The thing that has probably helped me the most is going for physical therapy, but for strength training. Um,
Mm,
I go to make sure that my legs, my core, and my arms are really strong. And
mm,
that way, I feel safer when I'm outside in trying to keep my balance. And what I often told the people in my support group is I trust my body. I trust the strength of my body because I cannot count on my brain sometimes. And I have only fallen in the last 4.5 years. I have fallen 3 times. And 2 of them were just simply that I was in my house. I had been sitting on the couch in the evening and decided, okay, it's time to get up to go to bed. And I stood up, and I know that I always need to just kind of stand there for a period of time, really get my balance before I take a step. Well, I thought I was balanced, and I took a step, and clearly I was not balanced because I fell over sideways, just went right over like a log. And
mm,
so at least those 2 times I fell on carpeting and I was safe in my home. The only really dangerous fall that I have had was on a staircase. And it's the only time I've traveled without my husband with me because he really knows when and how to help me. And stairs are my greatest sort of danger place. And I stepped up on the top step. There was not a railing for me to hang on to. And I had my walker for me to reach out to. And someone who thought they were going to help me moved my walker And so I had nothing to take a hold of. And when I am only on one foot and I'm stepping up is when I'm at my greatest risk. And I
Oh,
fell, I ended up breaking a finger.
Nancy, it makes so much sense that the strength training that you're talking about is helping. I mean, it makes sense to me, and maybe Dr. Cha, you can confirm this, but I've learned and I've heard from other patients that reduced anxiety, confidence, and trust in our bodies are a huge part of bringing our symptoms down because there is some connection between our fight or flight system and the dizziness. Maybe Dr. Cha, you can confirm or deny this. But I also, and on the tail of that, I also am interested to hear if you found a difference between, I don't know if you're doing brain imaging, but what that patterning looks like with non-motion triggered oscillatory vertigo and also the motion triggered patients.
Yeah, so more and more of our data now is moving towards both motion and non-motion triggered persistent oscillating vertigo is essentially being the same disorder, but with two different entry points. And in both cases, we see a very, very high burden of compression of veins in the neck and in the thoracic outlet. And the compression of the veins can go from the skull base, at the first cervical vertebra, all the way down to the base of the neck in the thoracic outlet. What probably happens in Mal de Debarquement, if you're on a boat, is that you have kind of these frequent adjustments of your head to maintain a steady head when your feet are moving because your feet are planted on the boat. On an airplane, I think it's a different situation where people are now sardined in airplane seats, right? Because they're so narrowed and they often have their head down. And so being in an airplane is more postural strain in terms of why that particular motion can trigger MdDS. For the non-motion triggered patients, I mean, you have everything from whiplash, concussions causing cervical misalignment, people have neck surgery, they undergo periods of inflammation, including from COVID, including from vaccinations. And so I found it really interesting that Nancy got tinnitus after a vaccination. And because we see a lot of thoracic outlet venous compression in people with Mal de Debarquement, and if your underlying vulnerability is high and you inflame the area just a little bit more, that you are at higher risk of just being sort of like pushed over the edge. So what we're now trying to figure out is if we can sort of predict or correlate the degree of compression burden with the mechanism, of the symptom onset, right? So do people with spontaneous onset of oscillating vertigo have more compression at the skull base, for example? Generally, what we see is that people with Mal de Debarquement syndrome tend to have a little bit more compression in the neck, like under muscles. And that's probably because of their trigger being, the actual head motion. But the bottom line is that we tend to see both bilateral compression and tandem compression. And if you think about the function of the venous system in terms of draining blood out of the head and helping with CSF clearance, then it makes sense, right? That people get headaches, they get brain fog, chronic fatigue, visual problems, and that a lot of their symptoms are worsened with head rotation. The two big head movement triggers are head rotation and head flexion. And so while people with oscillating vertigo tend to feel better with passive motion, like if they have their head still in a car, they actually will feel worse with head motion. And that's a really important distinguishing feature. We should not put all types of motion into the same bucket. So I think this will be really interesting to keep looking into, because I think MdDS, even though we consider it to be a rare disorder, it's actually not rare. It's actually kind of a window into understanding other labeled abstract concepts, right? Like cervicogenic dizziness or PPPD or vestibular migraine or even like post-concussive
So are
dizziness.
you saying even that, so just to go back to Nancy about the confidence that she feels after weight training, and that potentially maybe even the anxiety of walking with dizziness can constrict the venous flow, and that is potentially what you're finding in this research? And
Absolutely. So, there's a multi-layered input, to why people feel unwell, right? And so there's a whole field about the embodiment of emotion. And when people are anxious, I mean, what do, right? You tense your muscles, and you tend to, you roll your shoulders forward. You try to get into this like protective position. The last thing that people want to do when they feel anxious is to put their head back and stretch their shoulders back, which is exactly what we need for people to do when they start, feeling badly, with their headaches and their vertigo, is to actually have more of an open posture. And then there's other effects such as, raising, stress hormone levels that start affecting vascular tone. And if those things also then have a feed forward cycle of causing more venous compression with more tissue edema, which causes more venous compression, that's how you can potentially get into a big rut, right? Until hopefully, you can sort of wind the process back. So it's a little bit non-intuitive sometimes when people feel bad to just say, try to relax, take a deep breath, it's not really just trying to fix your head. It's actually trying to fix the relationship that your feelings and your emotions have on your body. And we've gotten so far into thinking of people as being just cognitive beings that we forget that our brains are connected to our bodies through our necks. And it's we just have to start being a little bit more humble that we are physical beings, right? That and the state of our bodies does act back onto the state of our brain.
this is so fascinating.
Dr. Cha, can I ask you a question? You mentioned that MdDS and the vascular component is a window into other conditions like triple PD. And I hear on many of the forums, the online forums, a lot of triple PD patients saying that they are, or MdDS patients saying they're misdiagnosed or diagnosed with triple PD. What is the relationship between those two conditions?
So I think first we have to kind of step back and think about all of these labels as being made by committees, right? Without an underlying biological model. And not to say that they're not helpful, because I've been involved in the creation of diagnostic criteria and these labels. Labels are important because they also restrict the creation of a whole bunch of random labels, right? So I think the creation of PPPD was really important because it actually narrowed the terminology that we use. But it doesn't mean that any label that we create, whether it's MdDS or triple PD or vestibular migraine, it doesn't come with an underlying sort of understanding of like this is what causes it, right? So we almost kind of go backwards. But I would say it's more like an iterative process, right? So we say, okay, we're gonna give this set of symptoms, a label, that we're going to try to study this sort of prescribed set of patients. We'll see what it shows, then we see whether we need to modify it. That's how all diagnostic criteria have been made. So I don't think we're in a bad place, but I do think that we have to be sort of humble about the fact that these labels are also abstract, right? And I think the labels are helpful to patients insofar as you get a label and it's not, this is a psychogenic, it's just your anxiety. So I think there's usefulness there. But I think it also does some degree of harm where now we sort of set patients up to be very confused, right? That is it MdDS? Is it PPPD? Is it vestibular migraine? Is it probable Meniere's disease? When the symptoms actually overlap between all of these disorders, and they are not defined really, by any kind of like underlying biology. And so this is why I just say, okay, just step back, and I think we have to kind of live through this period of things being a little bit muddy. But I think that there is light and clarity at the other end, as long as we don't become too dogmatic, about these labels, and about how much we have. We have to be humble about how much more we have sort of left to learn. And I think it's really exciting to think about new pathophysiological models. Until 12 years ago, it was just assumed that the brain did not have a lymphatic system, and now, some really bright and brave investigators at the University of Copenhagen said, actually there is a lymphatic system. It's called the glymphatic system. And it's super, super important in the clearance of brain metabolites and abnormal proteins. And guess what? The venous system is incredibly important in lymphatic clearance. So now, now you kind of tie in this other system that until 12 years ago, people didn't even incorporate into their pathological models. Now you say, okay, oh, by the way, we don't even think about the venous system's role in regulating intracranial pressure until very recently. So I think some of these terms are going to start having an evolution of their own as we start understanding how there's sort of a breadth to way the brain can be sick.
Right. So the more we know, the more we realize we don't know.
But we also now have more treatments, and we also can have better understanding of why prior treatments have worked in certain people, but not in other people, right? And that's, I think, sometimes the difficulty that patients face is, why did this work for this patient? And then, it seemed to be like a home run, but in me, it didn't work at all. Yeah. And I think, looking at, more pathways in the body is really important to, kind of tease out some of those differences.
Well, one thing that makes me think about is the role that fear plays in your symptoms, and accepting, being able to accept, in your case, Nancy, your constant sensation of motion. So can you talk a little bit about that? How has your attitude toward this condition affected the outcomes?
Right. Well, in the beginning, when this all started for me, after getting off the boat in Miami, and just thinking, oh, well, this is my normal 3-week extension of my cruise, which, I'd always say, I'm on a cheap cruise. This is great. And I get to go for 3 more weeks. Woohoo. But I discovered that things like taking a shower was a nightmare for me. Anytime that I'm in a smaller space, like being in a dressing room, say in a store, or being in a narrow hallway, increases my feelings of rocking back and forth. Being in the shower was such a nightmare that, it was honestly, I just said, I would tell my husband, I am living in a nightmare when I'm in the shower. So my solution for that was, and it's like, okay, I've been taking showers now for 4.5 years. I took one this morning, and what I do is I pretend to myself that I'm surfing. So I don't let the waves bother me. That's number one. And I stand with my feet even like I'm in a surfer's position. And if I need to, I've got my hands out to help me balance. The other thing I do is that I have music that I play, and I sing to it while I'm in the shower. And I focus on the music, I focus on my singing, I do not focus on my physical sensations. And that's one of the things that I have found has really helped me is, and I tell my support group people all the time, it takes time, but I focus on what I'm doing, not on how I'm feeling. And I no longer constantly describe how I'm feeling to myself or to
Mhm.
somebody like my husband who's in the room with me. But I am never without those sensations. And I've learned how to handle them. Like when I'm in the kitchen and I'm cooking, I always have my left hand is always laying on the counter like this and
Mhm.
hanging onto the chopping board while I only cut with this hand. And then I'm very careful. And if the rocking and rolling gets to be too much, and it eventually does after about 15 minutes, I'll usually say, okay, my boat's rocking a little too much. I need to go sit down for a few minutes and let this kind of settle down. Um, I I can honestly say that the only thing that truly gave me fear and still does is escalators. I will not go on them. I can't even look at them. They make me feel I thankfully I don't suffer from anxiety, so I'm um, I look at everything and before I do things that I know put me at risk, I just say to myself, I can do this. I'm strong. My body is strong. Stairs were a major issue for me, and it took me 3.5 months of working at physical therapy to be able to handle going up and down, even 4 stairs. Because for me, going up and down stairs is like I'm on a boat that's going like this, going up and going down. And so when I get to the top, I'm really unbalanced. When I get to the bottom, I'm really unbalanced. And while I'm on the stairs, I feel like I'm stepping into a canoe that's tipping over. So I just would say to myself before I would start the stairs, I can do this, and I am not going to be afraid of this. So I feel like I'm going to tip over. Okay, that's fine. Hang on to the railing, you know, and I focus on what it is that I'm heading to, that I want to do, which is why I travel. I've been to Antarctica. I went to Pompeii a month ago. I'm the only person out there with a walker, although they don't allow walkers on Antarctica. So I had to learn how to work with some walking sticks that I could balance with. It's not the way anybody else uses them, but it worked for me. And I am absolutely not allowing living with this balance disorder stop me from living the life that I wanted to live before this happened. And
Nancy, you are such a great teacher to us. I mean, what a I want you to make posters for patients because that I took me a long time to get there, but I'm in that same place now where it's like I'm just most days, even if I'm having a really dizzy day, my husband doesn't even know it anymore. And it's like, oh, well, this is what it is. And you have grace with yourself and you allow it to be part of your existence and you keep going. And there's something that happens with that
yeah,
that is transformative. And I also I want to go back to the shower thing and then tie you back in again, Dr. Cha, because the shower, same with me. It's like as soon as the water hits, crazy. But I've found, and maybe this ties to the vascular system, but if I let the water drop on my head, like full force, really warm, and just tolerate that sensation for a good minute, and it always brings my symptoms down after a period of time. And I'm wondering if there's some sort of opening of the vasculature that just sort of flushes but it hands down, if I resist it, I'm screwed. It's terrible. But if I just let the water flow and wash over me and let the warmth do its thing, it always brings my symptoms down. I want you to maybe come in here, Dr. Cha, and tell me about this wonderful new approach that you're working with, and what other suggestions you might have for MDDS patients who are listening to this and curious about this new approach.
Yeah, so this is definitely a new approach to not only treating MdDS, but also vestibular migraine, some cases of probable Meniere's disease, PPPD. And I kind of stumbled upon it because I had been working with patients with just intractable headaches who had gotten significant headache relief after they had thoracic outlet surgery. And I was really lucky to be able to work with some very patient vascular surgeons and interventional radiologists who are very interested in the venous system to understand that this is how the venous system behaves. That's very different from the way that the arterial system behaves. And so when I moved to the University of Minnesota about 5 years ago, I was kind of lucky enough to work with a really good radiology department with excellent radiology techs to develop a protocol of doing quantitative venous ultrasound in the neck and thoracic outlet and doing 2 head position CT venograms. And so we would do 1 head position neutral and then 1 in the head position that would exacerbate the patient's symptoms. Of course, it could be multiple head positions, but we'd always kind of just pick the one that was the worst. And so what we found is that the venous compressions happen in basically 3 places. So the first is at the level of the first cervical vertebra. And this is really, really important because this is where you have a lot of freedom of movement in your neck and where you can get very easily malaligned from fender benders and obviously things like whiplash and concussion, but also just from chronic bad posture, like looking down at your phone or your computer. The second place is in the mid-neck under the sternocleidomastoid muscle. This is a very, you're not the first people to describe this, but I think we're the first group to really look at this point of compression in a really large way. And I think this is going to be really important because of the role of muscular inflammation, including after COVID and other viral illnesses, that can be risk factors for compression at this level. And then the third place is in the thoracic outlet. So the veins that are involved are, of course, the internal jugular vein that drains the inside of the skull, and the subclavian vein that drains the arm. There's a very high number of collateral veins in between these 2 big veins. And when we see these compressions, like, for example, if you do a catheter venogram and you squirt some dye into the veins in people who have these compressions, what you'll see is that, that blood has to go somewhere, and, it's supposed to go straight down, right, back to the heart. But if you induce a compression, the blood will just go wherever the path of least resistance is. Sometimes it is straight back up the head around the inner ear. Sometimes it is toward the spinal cord. And if you start thinking about where the blood shunts to, the head, the brainstem, the spinal cord, then a lot of symptoms start to make sense, right? The headache, the vertigo, the tinnitus, the facial pain, the neck pain, and even symptoms in the legs, like leg heaviness and tingling in the feet that no one can figure out. EMGs are normal and the symptoms come and go. So what we do is to try to diagnose where all of the compressions are and then to target the treatment based on what we see. Most patients will have symptoms on both sides on more than one level. So if the compression is at the base of the skull, or in the neck or in the thoracic outlet, the treatment will be slightly different, but we always start with a very good neck physical therapy program. I'll tell you that vestibular therapy does not help, and in fact can make it worse, because as you turn your neck, you're actually inducing these compressions more. But we always start with good neck physical therapy, strengthening the back of the neck, loosening and stretching muscles in the front of the neck, because that's where the vascular system is running. We work on posture, ergonomic awareness, opening up your shoulders, sitting straight, avoiding situations where you're cramped. And if that is not helpful, then we have to escalate to things like doing, neurotoxin injections in the neck. We even have a few people who've gone to surgery to decompress wherever the location of the compression is. And again, that could be at the atlas, in the mid neck under the muscle or at the thoracic outlet.
Wow.
Wow.
I would not have imagined that the neck would play such a role in this particular, or in, vestibular disorders in general. And I feel like we've only just touched on the tip of the iceberg here.
I know, and I feel like I shouldn't be mad at my first neurologist anymore after 8 years cursing him for telling me I had cervicogenic vertigo. Maybe he was right.
Well, cervicogenic vertigo has had a very difficult time developing any diagnostic criteria because there's nothing that is kind of associated with it, except that now, we're looking at the other vascular system, right, that has been ignored for, all this time. And I think we're going to be able to make some headway in understanding why turning the head can trigger vestibular.
Wow.
Wow. Thank you for that. That is going to just, I think so many people listening to this today are going to be like, wow, I've never heard that. I'm going to go talk to my doctor about that.
Yeah.
I want to give a quick shout out, Nancy, to your new support group for anyone who is listening. So Nancy started a new support group specifically for Mal de Debarquement patients, and I hope that you'll go to Vita's website, look under coping and support groups, online support groups, to get that information, or contact us and we can get you connected to Nancy and her support group. Thank you both so much. I really do feel like we've only touched the tip of the iceberg here.
I know. And a quick question, Dr. Cha, for those who might want to pursue more of this understanding of their own potential vascular compressions, where would you send them? To get the right
Well, they
imaging?
should always talk with their doctor first. I'm happy to talk to their doctors about the protocol that we're using. It's not a difficult protocol. I mean, any place that does carotid Dopplers can, they have all the equipment. It's just a matter of getting the technicians to make the measurements on the vein side. And I have shared this protocol with tons of people. I will say that we're kind of in the infancy, of this area. So don't be too frustrated or too critical of your doctor, because we are, in the phase right now of trying to, kind of roll out this new pathology as another kind of explanatory variable. It won't explain everything, but it will be able to explain, I think a nice chunk of what we're seeing.
Amazing. Thank you both.
Thank you very much.
Wonderful conversation.
Thank you. It's a pleasure.
So anyone who wants more information about Mal de Debarquement, go to Vita's website, and we're going to put some resources in the link associated with this podcast as well. Thanks, everybody. Good night. Thanks for tuning in to ICU this month.
We hope this conversation sparked new understanding of the vestibular journey. And for all of our patients out there, leaves you feeling just a little more heard and a little more seen. I see you.